the patient may lose responsiveness, lose consciousness, and or develop symptoms relative to the cardiovascular system. In that circumstance, the appropriate thing to do is to stop the procedure, to give oxygen, and to monitor the patient carefully, because oftentimes they will regain consciousness or they will, with some stimulation, regain their circulation. The first maneuver to make when the patient develops an obstructed airway is to help to clear the airway by lifting the tongue off the floor of the pharynx. The simplest way to do that is to elevate the mandible by putting your fingers in the corners of the mandible and lifting upward. The tongue bone's connected to the jawbone, so if you lift the jawbone, you'll lift the tongue off the floor of the pharynx. An adjunctive maneuver is to rotate the head backward slightly to help to open the airway. You'll notice also that we have the patient resting on this foam pillow so that they're elevated somewhat in what we call the anatomic sniffing position. By lifting the head, by rocking the jaw backward, by elevating the mandible, we can open the airway. It should also be noted that by just putting our fingers here under the angle of the mandible and lifting, that's somewhat uncomfortable and stimulating the patient, and many times patients, when you do this, will say, take a deep breath. The first step in splinting the airway, once you've opened it with a jaw thrust, is to place an oropharyngeal airway or a nasopharyngeal airway. And this is best done by making sure the airway is somewhat lubricated, although most patients have a little bit of saliva. So we'll take a bit of lubricant here and just lubricate the back and the front of the airway. An important step now when inserting the airway is to make sure that you don't aggravate the problem by balling the tongue up and pushing it further down in the pharynx. So the simplest thing is to just place the airway in the mouth upside down and then track it along the hard palate. You can feel the hard palate till you reach the rear and rotate it around and in. In so doing, you avoid pushing the tongue further down into the pharynx. And then again, elevate the mandible. Most patients will take a deep breath at this point because you've relieved the obstruction with a rubber splint. This is a standard size airway. This is a large patient, so it might be appropriate actually to use a slightly larger. This is a size 5 oropharyngeal airway. Again, along the hard palate, rotate down and in. Lift the mandible. Sometimes we secure the airway with our thumbs. While the standard approach to placing the airway is to rotate it in along the hard palate, another method that's commonly used to advantage is to use 1 or 2 tongue blades, depress the tongue directly, and place the airway in the corner of the mouth, rotate it around and in. Oftentimes, the tongue blades compressing the tongue is of advantage, which is why I wanted to show you that technique. And sometimes 2 is better than 1 because 1 might be a little bit too soft. Many patients, even though they have airway difficulty, will not tolerate the placement of an oropharyngeal airway because they'll be reactive enough that if you place this in their throat, they'll retch or gag or vomit, and that's undesirable. And so there's many patients who will, however, be easily rescued by placement of another form of airway splint, a nasopharyngeal airway, and this goes in the nasopharynx. This one happens to be latex, and this is a non-latex version. This one's a little stiffer. In any event, when we place this in the nasopharynx, you notice the bevel edge is down. Place it in the nostril, and we aim for the ear canal because the nasopharynx goes back in a straight line and then makes a sharp turn posteriorly. So we aim right for the ear canal, and then when you feel just a little resistance, we rotate slightly and slide it into the posterior pharynx. This again achieves the same goal as the oral airway and is sometimes better tolerated by patients who are in an in-between zone of consciousness. Sometimes there is an occasional advantage to placing a second airway in the other nostril, though most patients, if they're not being assisted by 1, 2 is not necessarily better. But again, you can see that it's quite possible to place a second airway. A word of caution is that nasal airways must be placed with care in patients who are anticoagulated because the potential for a significant nosebleed is always there. Many patients will be helped sufficiently by placing an artificial airway that that's all they need, that and supplemental oxygen. But for some patients in the rescue algorithm, it's necessary to support their respirations with a bag mask ventilation technique. Again, most patients are helped by having an oral airway in, so we'll start by placing the oropharyngeal airway. And then we want to bring the mask to the patient. And I want to demonstrate carefully the best way to apply the mask to the patient's face. When applying the mask to the patient's face, you want to take the mask in your hands, drape it over the bridge of the nose, apply it to the mandible, thumb above, index finger below, 3 fingers on the mandible, with the baby finger lifting at the angle of the mandible. On difficult situations, you can apply 2 hands and elevate the mandible with 2 hands. In that circumstance, you need someone else to squeeze the resuscitator bag. We also have shown in place here a head strap, and it can be often very helpful to apply a head strap to the mask so that you don't have to use all your strength in managing the mask fit. So I can just put 2 of the straps on. All right. Again, elevating the mandible. This allows us to get a good fit. Many times when doing bag mask ventilation, there will be a little bit of leaking of air from the sides of the face. And if we just roll our hand over slightly while elevating and making a good fit with the mask, that's the best circumstance for resuscitating the patient. In many circumstances, you may not have a head strap available, and it's a useful adjunct, but by no means mandatory. The most important thing is to have a good mask fit, which you do with your hand. And when it comes time to use the Ambu bag, you'll notice what we do is turn on.
The American Heart Association, in their BLS and ACLS guidelines, advocates running the liter flow to a bag valve mask at 10 to 15 liters per minute.
You apply the mask to the bag. Again, drape the mask over the face, thumb above, index below, 3 fingers on the mandible, and just gently ventilate the patient. And you notice the lungs going up and down with your tidal respirations, and the stomach is staying flat. That's your goal and objective. When you're doing this with other rescuers, it's often helpful to have someone listen in the patient's axilla with a stethoscope to make sure that you're ventilating the lungs well. Again, you can see that with my left hand, I'm slightly rocking over with a mask to obviate a leak of gas from under the mask by the cheek. I brought this mask to show you. This is an anesthesia type mask, and it has some advantages over the standard mask that comes with a resuscitation bag in that it is somewhat more form-fitting and has a softer color, so it will make a somewhat better face fit. It has the disadvantage in that it's very size dependent and it's not clear, so you can't see through it the effects of your tidal respiration. So again, the advantage of the anesthesia mask, a little bit more form-fitting, but it's very size dependent, and it's not usually stocked in most sedating locations, nor is it necessary. Among the first aid maneuvers for the airway is to make sure that there are no accumulated secretions or that the patient has not regurgitated into the airway. And to do that, we use a standard suction device. This is called a Yankauer sucker. We turn on the suction, and again, coming from the side of the patient's mouth, we insert this into the pharynx, especially if you can see any accumulated material, and just aspirate it clean and free. That is often beneficial to the patient because secretions in the airway may stimulate coughing or gagging or other unwanted airway reflexes. The most important thing is to make a quick and early diagnosis of the nature of the problem. Is it primarily an airway problem, or is it primarily a circulatory problem? It may be both, but in that instance, it's important to guide the therapy to the needs of the patient. The record should obviously be a faithful rendition of the patient's status during the event, including the vital signs and the timing of the events and the interventions. If it's a respiratory event, then supporting the airway, maintaining a patent airway, up to and including securing the airway is the important step. If it involves the circulation, then it needs to be guided pharmacotherapy in many circumstances in terms of what medications are needed to help to restore the circulation. If we have an adverse event during sedation, it's very important to monitor that from a quality management standpoint. Try to analyze what caused it and then to put in play a corrective action plan. If there's an adverse drug response specifically, then it's very important to go through the normal pharmacy and therapeutics reporting mechanism for that so that other staff members can learn from our experience. A provider should absolutely not be apprehensive about reporting an adverse experience with a patient. It's the only way that we can learn from our experiences. If there has been an adverse drug response, there is a formal process through the Pharmacy and Therapeutics Committee for doing this. Each sedating location and unit has its own process improvement methods for tracking adverse events to make sure that we learn from them for the benefit of the next patient.